Hello, this is the second video in the series of videos on the use of this funny, nice, capable little device. NMES 10s in a small handheld package. It's called the Primera and it is made by Chattanooga and is a fantastic tool. It really is very straightforward to use, but very powerful and able to do pretty much most of what a clinician like a PT, an OT would like to do, or an athletic trainer, or a chiropractor, or anybody who uses electrotherapy, whatever they might want to do in a clinical setting. So this video is going to quickly review the various clinical avenues one might want to pursue with this tool. So let's get going into it. If you haven't seen it yet, the previous video that we recorded earlier is about the features. What can you find inside of the device and how do you operate it? Very quick 3-minute video. This one is going to be a little bit longer, but not very long. And then the video I'll do after this is going to be how do you actually find the programs in here that we will discuss right now. So let's get into it. Consider the following clinical dilemma. You have a 62-year-old male. He had a total knee replacement. He is in a skilled nursing facility. He's had surgery 2 weeks ago, and his risk factors are diabetes, he's deconditioned, he's got fear of falling, he has pain in his knee, of course, from the surgery, and he did fall 3 months ago. When you look at this picture and you know your risk factors for actual falling, this is a problem case. This man may fall. He's actually likely to fall in the next few months. The problem that the therapist wants to address is weakness, but the problem is he is not participating in exercise very well because of the pain, because of his fear of falling, etc. So what to do? Exercise is going to get him stronger, but he doesn't want to exercise or he's fearful of exercising. So you need a tool to help him get through this. And as you might guess, this is your tool that is going to help you overcome this dilemma. Or take another dilemma. 55-year-old female. She's had a stroke with right hemiparesis. Her right side is paralyzed. In skilled nursing facility, this one as well. She had the CVA 6 weeks ago. She has significant pain in the right shoulder. Referring to the elbow and hand, her shoulder is probably subluxating as well. The problem that you're faced with is that this arm is weak and she's receiving too little efferent neural traffic. Her muscles are not being told to move because of the stroke, obviously. So the exercise would be really appropriate for her. However, pain is inhibiting her participation in this exercise. Every time she tries to move, even with the help of the therapist, her shoulder is acting up and is causing pain. You want to exercise, you need to exercise, but you cannot exercise. It's a similar dilemma as before. In this case, it's more pain that is the real obstacle. Again, this tool can really break through this dilemma and allow you, the therapist, to deal with this patient effectively and strengthen them. So let's dive into how you would use this device. What kind of mental mindset must the therapist have in order to pick the right protocol on this device if you decide to use it as a treatment tool? So here's the typical progression in rehab that we typically pursue for those clinicians who are in rehab. You're dealing with an impairment, which could be weakness, pain, immobility, whatever the impairment is. That requires rehab, exercise, a variety of modalities, practice, compensation maybe to teach it, and all that is supposed to lead to functional improvements, such as better strength, better range of motion, and that, of course, leads to better functional movements, better reaching and grasping and performance in activities of daily living. Where it often goes wrong is you have the same impairment, you have the same rehab that is needed, but that rehab is now impeded because there's too much pain, or because there's dysphagia, or because there are wounds. There are things in the clinical picture that make it hard for the clinician to deliver that rehab. That may then precipitate the occurrence of adverse events like falls, like infections, like pneumonia, like readmissions to the hospital, you name it, all the things that we don't want. All of those things may happen or do eventually happen because at some point in time the rehab activities were difficult to execute. And this is where I think the sweet spot of tools like this in the hands of a skilled clinician can be extremely useful. It's really it's a way to break through this impasse in rehab. So electrotherapy, when used skillfully, has the ability to effectively inhibit pain and deliver muscle strength, muscle strengthening, at least the impetus for it. It can make the muscle work even when the patient doesn't want to exercise or cannot exercise. It can inhibit pain. So it can do these things very effectively. How do you approach that? In this tool, the Primera, since these videos are about this, there are both programs or both approaches built in. And in the literature or in the industry, we call these TENS and NMES. Transcutaneous electrical nerve stimulation is when you apply it for pain control, and NMES, neuromuscular electrical stimulation, is when you apply it for muscle strengthening. It's really the same electrical impulse. There are just slightly different parameter settings that are applied and slightly different intensities. And of course, the clinician, when he works with the patient, does slightly different activities. So that makes it then more appropriate for the one or for the other. If you think of pain, to make it simple, you can pursue one of two big categories of pain relief. There are more than just those two, but these two are the main ones. First of all, you could block the pain right now with setting up the device a certain way with the electrodes in a certain spot. In order to block the pain right now, you are going to be working according to the gate control theory. Typically, the devices emit a high rate, a high frequency of stimuli, and the intensity is not that high. It's moderately high. The patient feels it, but it's not like intense. It's not painful. It feels quite comfortable, actually. The effect that the patient will perceive, the inhibiting effect on pain, the analgesic effect, is going to be perceived right now during the treatment. The patient feels the stimuli as opposed to feeling the pain. The typical mistake that people make when they execute this treatment is they have the patient not exercise when the stimuli are active. So in other words, the window of opportunity to do your exercise, because that's after all what we are trying to do, the window of opportunity is right now. While the patient feels this, the pain is less. Once the electrodes are off, the treatment is done, that pain will come back. In other words, it's not curative at all. The second way you can approach pain control is the opiate release. This is when you use a much lower rate, the frequency is much lower, and the intensity is much higher, much more intense, almost painful even. The effect here is apparent mostly about 10-15 minutes after the treatment has stopped. The brain is producing chemicals, and those chemicals, once they are in sufficient quantities in the blood, those chemicals will eventually suppress the pain. So the typical mistake here that people do is they keep the intensity too low. They say to the patient, tell me when you feel it. Okay, let's make it a bit stronger. Okay, is that strong? Yes, okay, let's leave it there. Instead, they should go, tell me when it's nice and strong, and then bump it up even a bit further. So the patient is like, oof, this is really limit. I can almost not take anymore. All right, if you look at NMES, you can equally simplify the approach in two broad categories. Again, there's more than these two ways, but these two are two big ones. So you could either be focusing on building endurance or stability around a joint. When you do that, you're going to use a lower rate, moderate intensity, and a high number of repetitions. This feels quite comfortable. The NMES that you're going to deliver, the stimuli that you're going to deliver, is going to get a muscle contraction, and the patient is going to work with the contraction. He's going to feel the contraction, and then he's going to do his exercise. And then the machine stops, and he stops. And then it starts again, and he starts again. So essentially, the machine will start acting as a pacemaker, so to speak, where he paces the patient in their exercise execution. The typical mistake that people make here is that they don't do any exercise while the stimulation is running, kind of similar to the gate control mistake. So they set up the patient and they turn on the machine and they say, okay, I'll be back in 10-15 minutes when the machine is done, and then we'll do our exercises. No, do the exercises when the machine is delivering the stimuli. Work with the machine. The second way to approach muscle strengthening is when you want to build explosive capabilities. It's a different fiber type entirely that does this work. Here you're trying to build the ability of the muscle to react quickly. So for example, in the vastus medialis, the thigh, to prevent a fall. When the machine is trying to assist this, you typically use a higher rate, a higher frequency on the device. The intensity is higher as well, but the repetitions are lower. To kind of think about it easily or to remember more easily, think of the gym. If you go to the gym and you build and you work out in order to support your work to run a marathon, you're going to use more reps at a lower intensity. But if on the other hand, you're trying to build bulk and power and weightlifting capabilities, you're going to work very high intensity. You're going to push heavy weights and you're going to use lower reps. And it's kind of the same when you do this for your patient. So this feels like intense, hard work. The same principle, though, applies here when you do as you did for endurance. Do your exercises when the machine delivers the stimulus. So you feel the stimulus, now work with it as hard as you possibly can, and then relax. After 10 seconds, we'll take a break. After 10 repetitions, we'll take a break. The typical mistake people make here is they don't turn up the intensity high enough. And the same as before, they don't exercise at the same time as doing NMES. So, I hope this was kind of a good introduction to how to approach either pain control or muscle strengthening. Two options for pain control: either you do the gait control or you do opiate release. Two approaches for muscle strengthening: either you build static ability or you build explosive ability. So depending on what your patient needs, you'll pick the right program on this device to help you break through these clinical dilemmas. So the next video is going to be, how do I pick the right program? Which program on Primera do I pick in order to get my perfect outcome for my patient? I hope this was helpful. Send me an email to this email address if you need any further help. Thank you.